first topic in this section of ARDS. So first, today we will talk about the ARDS pathogenesis. Now, before moving on to the pathogenesis, first let's understand what ARDS is according to the Berlin definition. So, firstly, you should understand the timing. So, the worsening of the respiratory symptoms could be as a new onset or a worsening respiratory symptom, or the insult should happen within 1 week from that known clinical insult. On chest imaging, there should be bilateral opacities which are not fully explained by effusion, lobar or lung collapse or nodules. The origin of edema has to be something other than the cardiac part, cardiac failure, right? So it should be a non-cardiogenic type of a pulmonary edema, right? So in other words, what we can say is that respiratory failure is not fully explained by cardiac failure or any type of fluid overload. And finally, we have the division based on the values of PF ratios, like so it is mild when it is between 200 to 300, moderate is when it is between 100 to 200, and severe is when it is less than or equal to 100. Now remember that all this is measured with PEEP or a CPAP of more than 5 centimeters of water. Right now, this particular condition, that is ARDS, could happen as a result of certain direct causes and then direct pathways or indirect pathways. What I mean by direct pathway is that this do not require any intermediary mechanisms, right? The injury probably occurs as a result of a contact between an offending substance and a lung tissue. For example, in the cases of toxin induced, right? So the toxin is directly acting upon that barrier and destroying it, or it could be as a direct effect of bacterial infiltration, or it could be in the cases like drowning, etc. Indirect is when you require a participation of intermediary mechanisms. For example, the host defenses, right? The classical inflammatory mediator theory that is very famous in ARDS. So that is an example of indirect method, indirect pathway for ARDS to occur. Now, before moving on to ARDS per se, let's understand the pathogenesis of pulmonary edema. Now, as we all know that pulmonary edema is divided into a cardiogenic type of pulmonary edema and non-cardiogenic, right? In other words, they are divided into an increased pressure pulmonary edema and on the other side, increased permeability pulmonary edema. Now, on what basis do you do that? So this is the classical equation which actually is the determines which direction the fluid is going to move. Now, in this particular thing, the PC minus PI is the difference in the hydrostatic pressure between the capillaries and the interstitium. The pi C minus pi I is the difference between the oncotic pressure existing in the capillaries and the interstitium. LP is nothing but the permeability of the microvascular barrier. S is the surface area. Sigma D is the average osmotic reflection coefficient of the barrier. That is, it is the measure of effectiveness of the barrier in hindering passage of solutes, right? So based on this equation, when we talk about increased pressure pulmonary edema, this happens when the driving forces increase, right? This is a typical increased pressure, that is, whenever you have an increase in hydrostatic pressure, if there is an increase in the hydrostatic pressure in the capillaries, this would allow the fluid to filtrate into the alveolar space, and thus this would cause a increased pressure pulmonary edema, right? So then on the other part, we have increased permeability pulmonary edema, which would be our focus, which is actually ARDS, right? So what happens is that the barrier, the microvascular barrier which exists over there, that somehow is destroyed. And when this barrier is destroyed, the contents which are existing in the extravascular space or the interstitium can easily migrate into the alveolar space, causing various inflammatory mediators to occur over there, and it actually causes a cascade to form, which further causes lung injury and eventually the symptoms of shortness of breath and other symptoms of ARDS, right? So basically what happens is that, do I mean to say that accumulation always occurs in alveoli? Yes. But there is always this mechanism which causes the fluid to move back into the circulation, right? So there is always this facility existing in our body that if there is a tendency of fluid accumulation anywhere in the body, at the same time, there is always a mechanism or a transport method which is available to take that fluid out of that cavity again. But then in certain pathological conditions, what happens is that there is an abnormal accumulation, which either there is an increase in the accumulation of the fluid or the drainage is somewhere hindered, right? So whenever there is an abnormal accumulation of extravascular lung fluid in a pathological state, the fluid is filtered into the lungs faster than it can be removed, and this is something that causes all the pathology, right? So like we said, in increased permeability pulmonary edema, ARDS is the classical example to it, and there occurs a damage to the normal barrier. This causes congestion, atelectasis, and eventually pulmonary edema, right? Also, there is an increase in the liquid and protein conductance across the barrier in the lungs. This entity eventually causes what we call as non-cardiogenic pulmonary edema. What happens, like we asserted, the rate of fluid accumulation exceeds the rate at which it is removed. Causes could include bacteria, endotoxins, and microemboli, right? These are just one of the few causes, right? And uh, Another important point is that the edema formation in the injured lungs, that is also sensitive to the hydrostatic pressure. So it is not just the increased permeability of the barrier that is causing this condition, but also there is an increase in the hydrostatic pressure. Now, from where do you get an increased hydrostatic pressure? The vasoconstrictive effect of inflammatory mediators, which includes classically thromboxane. Thromboxane shifts the main site of the vascular resistance to the post-capillary venules. So whenever there is the shift of the vascular resistance to the post-capillary venules, the capillary hydrostatic pressure increases. And when this increases, this causes further fluid accumulation into the alveoli. So both the mechanisms are playing a role. There is an increased hydrostatic pressure, and at the same time, there is increased permeability that is existing. And all this leads to two main problems. One is there is increase in the lung vascular permeability, and the second is the lung vascular pressures and volume. They are also elevated, right? Another thing that happens is that the protective effect of protein osmotic pressure differences across them, they are also lost. So when this barrier is lost, as we say that proteins leak into the alveoli. Now when these proteins leak into the alveoli, it causes a decrease in the oncotic pressure that is existing in the capillaries. So when that happens, again, this also is not looking good for the lung or the alveoli. So when that protective effect of protein osmotic pressure is lost, again, fluid starts accumulating. Then now, after all this has happened in your lung, one thing that is for sure that your lung is injured, right? And what happens anywhere injury? What happens in the body when anywhere there is an injury? The driving in of neutrophils, right? So injured lung eventually activates the various inflammatory mediators via activated neutrophils, and at the same time the proteins which are existing inside the alveoli in that pathological state interact with the existing surfactant proteins which are already present in the alveoli, right? So all these conditions eventually lead to what? This leads to a reduced surfactant function, and the activated neutrophils, they degrade the major surfactant apoproteins through a combination of proteolysis and reactive oxygen species, right? So this is the pathology that exists over here. Then coming to the alveolar edema and what are the various stages of it. So in the earlier stages of alveolar edema, interestingly, it is homogeneous. It is non-gravitational. You would find a uniform increase in the edema all throughout the alveoli, right? And in this condition, there is a marked increase in the pulmonary dead space fraction. Why? Because the alveoli are not ventilated, and the pulmonary capillaries, they are not oxygenated, and that is why you get a dead space kind of a condition. Then after the early stage, we have the exudative phase. The exudative phase is interestingly gravity dependent, and finally you have the organizing phase, which eventually causes lung reticulation. Now, when you talk about the pathophysiology, the causes of ARDS or this existence of alveolar edema, there are many causes, but primarily it is caused by pneumonia, sepsis, gastric aspiration, major trauma, transfusion associated lung injuries, drug overdose, severe and acute pancreatitis, and near drowning, right? So these are the major causes of alveolar edema. And due to all these, what happens? Firstly, as we all know, the barrier is lost, so the gas exchange would be severely compromised. Now, when gas exchange is compromised, what happens? There is an intrapulmonary shunting and there is a VQ abnormalities, right? Then again, next thing that happens is chest wall compliance is reduced by abdominal distension, chest wall edema, and pleural effusion. Bronchospasm is found as a result of the inflammatory mediators. Then airflow resistance is increased as a result of decreased lung volumes. Decrease in static compliance occurs as a consequence of loss of ventilated lung units. So whenever you have so static compliance is reduced, right, because of loss of ventilated lung units. And finally, all this causes an accumulation of acute response cytokines and their naturally occurring inhibitors, oxidants, proteinases, antiproteinases, lipid mediators, growth factors, and collagen precursors, all of them which are involved in the repair process. So all these are affected in some way or the other, and that is why edema causes all these conditions. So you have chest wall compliance reduced, you have bronchospasm, gas exchange abnormalities, airflow resistance is increased, and there is a decrease in static compliance as well as accumulation of various inflammatory mediators. So this was about the pathophysiology. But what happens in the pathology? The earliest changes that you can actually observe in pathology includes widespread alveolar and interstitial edema along with inflammation and even hemorrhage. There is a formation of hyaline membranes and uh, damage to the type 1 and type 2 cells, but type 1 cells are more damaged as compared to type 2. This hyaline membrane formation is what eventually uh, is able to give the picture of diffuse alveolar damage or DAD, which is primarily the pathonomic feature of ARDS. After the earlier changes, we have the proliferative phase. Now in this phase, what happens? There is reabsorption of some of the edema, and the air blood barrier that may be thickened by interstitial and epithelial enlargement. So interstitial epithelial enlargement is there, so that causes a thickening of the air blood barrier. And when this thickening occurs, what happens? Due to this thickening, the pulmonary vascular bed that starts getting disrupted. And when this starts getting disrupted, what would eventually happen? A reduction in the surface area for gas exchange. So your DLC would be reduced, right? Just saying, right? So due to all this, that this happens. Do we have certain biomarkers for it? The next question is, well, yes, we do have biomarkers for this, right? This includes, but most of the time they are experimental, like von Willebrand factor. Von Willebrand factor was found to uh, you know demonstrate impending ARDS due to pulmonary sepsis, and eventually these patients have a poor clinical outcome. Apart from that, surfactant protein D, IL-6, plasma angiopoietin 2, and TNF or lipooxygenase elastase, all these cause acute lung injury with sepsis, right? Then coming to the mechanisms. Now, the mechanisms by which all these conditions, we talked about so far what we've done. We've talked about the definition of ARDS. We have talked about the causes or the different types of pulmonary edemas that exist in our body. Then we have talked about, in particular, alveolar edema. What are the various stages? What is the pathophysiology and what eventually happens? Coming now to the mechanisms of ARDS. Now, broadly speaking, there are three mechanisms that are involved in ARDS. The first one is infection, the second is inflammation, and the third is direct toxicity. So, infection can cause a direct damage or an indirect damage, which we studied in the first is a few minutes of the lecture. So there is a direct damage that can happen due to bacteria. There could be some indirect damage. Now indirect damage can happen as a result of endotoxins, lipopolysaccharides, as well as the mechanical ventilation which is actually used to treat ARDS that may predispose the patient for further bacterial infections. So when you talk about endotoxins, endotoxins can cause an inflammatory response. It can cause activation of the clotting system, and as a result of endotoxins there is a further as a result of endotoxin secretion there is injured epithelium, which kind of provides a breeding ground for further bacterial adherence, right? So there is increased adherence of the bacteria in this already damaged endothelium. And of course you have mechanical stretch. So increased adherence of bacteria to the injured endothelium. This is particularly seen in the cases of Pseudomonas exoenzyme U and elastase. Mechanical stretch is as a result of mechanical ventilation. Then on the other hand, we have lipopolysaccharide. This in particular enhances the response of alveolar macrophages to positive pressure ventilation. And mechanical ventilation in itself increases the sensitivity of the lung macrophages to endotoxins in vitro and the expression of endotoxin recognition molecule, that is CD14. So all these conditions cause eventually an increase in the inflammatory mediators, right? And of course lastly we have impaired antibacterial defenses, right? And there are certain genetic polymorphisms that exist which kind of predisposes an individual uh, uh, to a higher chance of getting infection, right? Now after infection, let's come to inflammation. Now when you talk about inflammation, the immune responses and hemostatic pathways may determine whether alveolar injury can be repaired and resolved, right? So the pathways that exist in this particular condition includes neutrophil activation and cell death pathways. So neutrophil activation, when it takes place, it causes sequestering of the neutrophils, right? So they are elongated. When this happens, there is more retention of these neutrophils in the pulmonary circulation. This eventually leads to increased expression of leukocyte adhesion molecules, which causes further migration of neutrophils into the air spaces. When this happens, finally, the toxins are released from the neutrophils in the form of proteases and cationic lysosomal enzymes. All these eventually do what? They cause damage with whatever they come in contact, right? And eventually, you have damage of microvascular and epithelial barriers, leading to hypermeability edema. Apart from that, it also activates cell death pathway. The death receptors, so called, that is FAS-L and TNF, they are activated, and there is shedding of the FAS-L into the circulation, which is also known as S-FAS-L, or circulating or free FAS-L. This enter the alveoli and induce epithelial cell death, and at the same time also travel to distant organs like kidneys, and they may even cause havoc over there, right? So this is about inflammation. And then we have direct toxicity. Now direct toxicity could happen, like we said, by direct effect of that insult. This is classically seen when the mechanical seen in the case of mechanical ventilation, where the mechanical forces during mechanical ventilation, toxic and corrosive chemicals and gases like hydrochloric acid, chlorine gas, or phosgene, or aspiration of fresh or salt water, like in near drowning conditions, cause this condition. Apart from that, we have aspiration of gastric secretions. Now, remember that the aspirated acid is almost immediately neutralized, but pro-inflammatory mediators are released within a span of few hours. So aspiration of gastric secretions does not cause the epithelial barrier disruption because of its acidic content, because acid is quickly neutralized. The problem exists with the pro-inflammatory mediators, right? Then after this, we've talked about mechanical ventilation so much, so let's talk a little bit about ventilator induced lung injury. Now, ventilation using a high tidal volume may increase the vascular filtration pressures, right? This increased pressure causes stress fractures in the microvascular endothelium, in the alveolar epithelium, and also in the basement membrane. And this causes lung rupture, right? So the injury appears to be due to increased lung excursions in high volume, and this is also known as thus trauma, right? Then apart from that, VILI also induces release of several pro-inflammatory cytokines, and they injure the lung and other organs as well. This is known as biotrauma. And then we finally come to, how to avoid this? Use a low tidal volume, right? So a low tidal volume would cause a reduction in the lung endothelium and epithelial injury, attenuated inflammatory response, reduced edema formation, and there is more rapid resolution of the lung edema, right? So all these things are very important. Now, coming to the resolution of acute lung injury, we missed out on this topic. So, there is always this condition. Now, we know that in normal circumstances, the fluid that is inside the alveoli has somewhere to go, right? So, fluid never accumulates. The body never ever dares to let a fluid accumulate anywhere in the body, right? So, by definition or by logic, edema can be cleared by a five routes, right? You have the lymphatics, you have the airways, you have the blood vessels, the pleural space, and the mediastinum, right? So, like we said, when the barrier is disrupted, the capacity to clear edema is lost. Now, the capacity to remove some alveolar edema fluid in the first 4 to 12 hours following ARDS is a favorable prognostic sign. And in these patients, the mortality is 20%. But if you are unable to resolve the alveolar edema fluid in the early course of the injury, the associated mortality increases to 80%. That is how important this transport is. Now, the resolution of ARDS, this requires effective number one, reabsorption of the alveolar edema, number two, repair of the epithelial and endothelial barriers, number three, removal of the inflammatory cells. So, it is happening on three fronts. To resolve ARDS, there are three goals of your treatment. Firstly, you should try to remove the fluid as much as possible. Secondly, you need to repair the damaged microalveolar, microvascular barriers. And thirdly, whatever inflammatory cells or mediators have been accumulated over there, you need to remove them too, right? And all this happens through vectorial transport of sodium chloride channels across the type 1 and type 2 cells, right? Now, but is it actually what happens in ARDS? No. This particular process is what is impaired in ARDS. Alveolar fluid clearance, or AFC, is increased by administration of beta 2 agonist like salmeterol. But the beta adrenergic mediated effect by augmentation of CAMP works primarily when when the alveolar epithelium is not injured, as in hydrostatic edema. So beta 2 agonists may play a role when the alveolar epithelium is not injured, but if it is injured, it is not going to play a very important role. Now, then interstitial water that is present in the pulmonary edema, it normally lies in the peribronchovascular loose connective tissue spaces. But the lymphatic channels which surround the alveoli, they are not responsible for clearing this fluid. So where does this fluid go? This drains into the bloodstream by crossing the walls of blood vessels in the lungs. And this may also drain into the pleural space. And that is why you get pleural effusions in approximately 20 to 50% of patients with ARDS. Apart from that, another way by which these inflammatory mediators are cleared out includes phagocytosis and catabolism by macrophages. Now, this accounts for most protein clearance from the alveolar space. So, you need to have healthy macrophages to do that. This not only removes not only removes the proteins, but also removes the senescent and dead neutrophils and other debris. Now, interestingly, the rate of alveolar fluid clearance is significantly slow in those without shock. AFC also, the rate of AFC in patients with shock was significantly slower than in those without shock, right? So AFC also decreased significantly as the number of vasopressors required increased, right? So whenever you have a shock, whenever the patient presents with shock, the alveolar fluid clearance is somewhere hampered. At the same time, whenever you use vasopressors, that also causes hindrance of this, right? So that is it. So I think that is sufficing our purpose. So with this, we end the discussion. Hope you had a good learning. Thank you.